Good morning, everybody. Good morning. Good to see you. We are going to talk about anemia, transfusion, and bleeding. I have the same disclosures. Nothing is relevant to this talk. So we're going to talk about anemia and transfusion. We're going to talk about how to manage preoperative anemia. We're going to talk about conservation techniques, blood conservation techniques. We'll go through a whole series of them, what works, what doesn't work. And we'll talk about transfusion triggers for red cells. First slide, just basic. Everyone knows anemia is bad and transfusion is bad. What this graphic is showing you is the type of complication is on the y-axis and the percent of complications is on the x-axis. And then the different colors represent whether or not you have just anemia, whether or not you have just transfusion, whether you have both, or whether you have neither. And the worst is when you have both. The best is when you have neither. Other complications are higher when you have one or the other or both. Nothing here that you don't already know about. The question is, why does this happen? We're going to why are these related, and what do you do to prevent it? So we do know that there are risks of allogeneic blood. There are infectious risks, I think everyone knows about, particularly from viral agents. Those are rare. It's about as rare as getting struck by lightning. People are concerned about it, but it's not common. The immunologic reactions are more common. The allergic reactions are the most common. When it comes to infectious risks, platelet transfusions have actually higher risk of bacterial infection than the viral infectious risks that are in red cells. But probably the most common is transfusion-associated circulatory overload. That's only 1 in 100. So why is anemia associated with risk? Is it because of the fact that it is associated with many chronic diseases? Probably. It's also a marker for acute and chronic bleeding. That's certainly a problem. It's associated with a reduction in physiologic reserve. It's certainly the biggest predictor of whether or not you're going to need a blood transfusion. And so all of these things are related to each other. Is it cause and effect? We don't know, but we certainly don't want patients to be anemic, and we prefer not to have to transfuse them. What can we do to identify patients who are at risk, and how can we treat them to improve risk? So here's just a thought-provoking question for you. I have a 65-year-old lady. She has rheumatoid arthritis. She has chronic anemia. She's scheduled to undergo a bilateral knee arthroplasty in 2 weeks. You see her meds there. Which of the following would you recommend that she do? She should get erythropoietin sub-Q and oral iron. She should get EPO sub-Q and IV iron. She should get lab testing for serum ferritin and iron saturation, or no additional lab tests and proceed to surgery. Just think about that for a moment. We're not going to come to the answer here, but think about what you would do in your practice, okay? So when it comes to diagnosing and treating preoperative anemia, there are a lot of causes for anemia here. We're not going to go through all the different causes, but when we're approaching the patient who has anemia preoperatively, really try to bucket them in. Is this an iron deficiency state or is this not? And there really are two kinds of low iron states. There's people who have true iron deficiency anemia, really defined by a ferritin, or they can have a chronic disease low iron state, as you can see there, but defined by a ferritin as well as an iron saturation. And then there are those who have normal iron stores but have chronic disease. When you have somebody who is iron deficient or just low iron, there are treatment options. You can give them iron supplementation, and it can be either IV or PO, and you can consider whether you're going to give them erythropoietin or not, and you can combine that with IV iron, oral iron, and which are better than iron alone, and we'll get to that data. So I'm going to show you some data from some randomized trials just to show what happens when you supplement. This is a study that was published in The Lancet some years ago. They looked at if we treat patients with IV iron before surgery, can we improve their outcomes, okay? They gave them 1,000 milligrams of ferric carboxymaltose or saline. It was about 2 weeks before surgery. And what they showed is if they did this, they could increase the hemoglobin by 0.5 milligram per deciliter on average by the operative day. They didn't change the number of patients who were transfused. They didn't change the 30-day death rate. They did note that they had fewer patients who were readmitted to the hospital. That was one interesting finding that they had. This is not what they were expecting. So few readmissions at 8 weeks. Now, you can combine erythropoietin with iron, and a lot of studies have done that. And if you combine the two together, you can get an even bigger boost in the hemoglobin, here about a gram per deciliter increase by the time you get to surgery. And it translates into a 50%, roughly a 50% reduction in the need for transfusion. It does not change in hospital length of stay. It doesn't change mortality, but you can reduce transfusion if you combine erythropoietin with iron. You can also reduce transfusion if you give IV iron with tranexamic acid. We're going to get to TXA in a little bit. So this was a randomized trial in orthopedic patients with a hip fracture. They were randomized into 4 groups, a double placebo group, those that just got TXA, those that got just iron, and those that got both TXA and iron. And you can see on this graphic on the right-hand side, on the y-axis is the cumulative probability of having an adverse event over time, and the lowest graph there is the combined group that got a combination of TXA and iron, and they had the lowest risk of complications, which mostly were translated into transfusion. So what are the risks and benefits of correcting preoperative anemia? I mean, there are some risks depending upon what you're going to use, and there are obviously some costs. If you improve hemoglobin, you can do that with iron alone. You can do it even better if you combine iron with erythropoietin. If you combine erythropoietin with iron, you can actually reduce the proportion of patients who are going to require an allogeneic transfusion. You can also combine TXA with iron. That will reduce the risk of transfusion. It's not really clear if any other outcome is improved. Again, there's that one study suggested perhaps you could have a reduction in readmissions, although that hasn't been borne out by other studies. No change in death, no change in hospital length of stay, but you can reduce transfusion. Are there risks? Well, of course there are risks. I didn't list the risks of IV iron, or there are some risks of even oral iron, at least the side effects to the patient. But there are risks of erythropoietin. There are some risks of theoretical thromboembolism. As I mentioned, there are no demonstrated benefits in terms of reducing mortality or other types of complications, lengths of stay, quality of life. And what's unclear, and I haven't really seen in the literature much on this, is this therapy of IV iron with erythropoietin, is it cost effective? And the reason I say that is we are very worried about transfusion, but it turns out the cost of a blood transfusion is lower than these therapies. So it's unclear to me what is the best therapy. I mean, we do want to avoid transfusion. Certainly patients don't like it, but I don't think the literature has answered that question. What are the guidelines? Again, this comes from the AHA guidelines that just came out a few months ago about anemia. They suggest that it is reasonable with patients who have iron deficiency anemia to replace iron, to reduce transfusions, and to increase hemoglobin. Again, there are certain ways you're going to do it. If you want to decrease transfusions, you're going to have to combine this with erythropoietin. A little note here, if you are going to give iron, you need time for it to work. If you have less than 2 weeks, oral iron isn't going to cut it. And there is potentially some benefit of supplementing your iron both preoperatively and postoperatively if you really want to get bang for your buck. So these are guidelines from the American Association of Blood Banking. What they suggest is that you diagnose anemia early, that if you find iron deficiency, you treat it with iron. And in patients who are undergoing orthopedic surgery, they suggest it's reasonable to consider the combination of iron with erythropoietin if your hemoglobin is less than 13, but they do not advise that you use this routinely. Now let's shift gears for a moment and talk about a number of strategies that are available to reduce the need for transfusion by conserving blood in the operating room. Okay, we're going to start with TXA. So what do the guidelines say? The guidelines say that using tranexamic acid is reasonable. It is reasonable to reduce transfusions and avoid anemia. And now we're going to go through, there's a lot of data on tranexamic acid. Some of the questions that are still to be answered, or perhaps questions you may have, is TXA beneficial in all surgical procedures? And what would be the optimal dose of TXA that you'd use? And is there a benefit of combining IV TXA, tranexamic acid, with more local dosing? A lot of literature on this topic in cardiac surgery. This is where it's been the most widely studied, and a number of different dosing regimens have been used. I'm showing you an important study that compared these two dosing regimens, a high dose regimen they called 30 milligrams per kilogram versus the low dose regimen, 10 milligrams per kilo. There have been studies in which they've even used higher, 50 or 100 milligrams per kilo. I don't advise you do that. They had complications. But in this study where they compared this 30 milligram per kilogram for 10 milligram per kilo and then the IV infusion, they found that the 30 milligram per kilogram, think about that for a moment, for a 100 kilogram person, that's about 3 grams, and then more, just put it in perspective. So think about 3 grams-ish. They found that the patients who had the higher dose had less transfusion, and they said that it was non-inferior from a safety point of view, although there is somewhat of a signal that there may be more seizures. But overall, that didn't translate into a problem for the patients. In orthopedic surgery, particularly total hip and total knee arthroplasty, this has been studied effectively. I mean, there's a lot of studies in this. And here, what the authors wanted to do is it beneficial to combine IV with local interjoint? And in this meta-analysis, and there have been others, what they found is that if you combine IV dosing with intra-articular dosing, that it's beneficial compared to either the IV dosing alone or the joint dosing alone. And they also found that doses of 3 grams total, that would be IV and along with the joint, are better than smaller dosages. Does tranexamic acid increase complications after surgery? Particularly, are we getting more thromboembolic complications? That's been the biggest concern. This is a series, again, meta-analysis of tens of thousands of patients. Most of these are actually come from the trauma literature. But in all kinds of different surgical procedures that have been shown, there isn't any real signal, as you can see on the kind of the left-hand set of these boxes, in terms of the risk. You see most of those values are negative. Some of them are positive, above 0. Don't worry about the number itself. But none of them are statistically significant in terms of VTE or a myocardial injury or stroke or arterial thrombosis. What is interesting is that regardless of the signal that you're getting here, unclear on thromboembolism, doesn't look like there's effect. It looks overall like there's a mortality benefit. In each of these cases, there was a negative number suggesting that it was better to have the TXA in terms of mortality. The only one that was significant, though, is in trauma. So I don't want you to think that in all of these cases you get more mortality benefit. But overall, in the meta-analysis, it looks like there's no safety signal from a mortality point of view. I want to talk a little bit about this POISE-3 trial. This was a big randomized clinical trial where they gave patients tranexamic acid to control bleeding in non-cardiac surgery. I already mentioned there's tons of studies in cardiac surgery. This is the biggest one, almost 10,000 patients that they randomized to either get TXA or not get TXA. Their main outcome here was life-threatening major bleeding and cardiovascular morbidity. And we can see on the graphic here on the left-hand side, this is the bleeding outcomes. And what you can see, in red is the TXA group. It's lower than the placebo group. You can definitely reduce bleeding in major non-cardiac surgery. And in this case, it was a mixture of orthopedic surgery combined with general surgery, abdominal, thoracic, GYN. It was a lot. Head and neck, you'll see in another slide. There was no effect on mortality or reoperation or length of stay. It would actually, the numbers here favor from a mortality point of view are slightly better for TXA. In the bottom right corner here was one of their main outcomes was it non-inferior from a safety point of view. And you can see that the numbers for TXA were numerically higher, meaning there were somewhat more complications, 14.2% versus placebo at 13.9%. This is not statistically significant, but it doesn't meet their non-inferiority threshold. So it definitely reduces bleeding and transfusion. It didn't reach their non-inferiority threshold. There was no change in mortality. How you want to interpret this study, is it positive, is it negative? That's kind of in the eye of the beholder. I think that it works. Most people think it works. It reduces transfusion and bleeding without causing complications, but that's up to your view. And then another study just published here, they wanted to see, was there anything, a signal here? If you looked at, did TXA have the same effect if you had general surgery versus non-general surgery? Again, this is that same trial, but just a stratified analysis. And what you can see here in this graphic is that whether you had general surgery or non-general surgery, you see the general surgery is intra-abdominal and head and neck, and everything else was non-general surgery. It doesn't matter. It was the same effect in terms of reducing transfusion and reducing bleeding outcomes. Again, and there was no difference between these in this stratified analysis of the safety signal either. Now, does it work in every surgical procedure? 2 publications just came out in the last year or so, one in liver surgery, one in cystectomy. And the answer is, in these 2 types of surgery, it doesn't seem to work. So the one in liver surgery, again, they got TXA versus placebo, and what they found is that it didn't affect, there was no effect on reducing transfusion or bleeding, and they saw a safety signal, meaning they have more complications. This is all kinds of complications in the TXA group. And in the cystectomy group, similarly, these are relatively small studies, but reasonable size compared to the POISE trial, but a reasonable size. They also did not see a benefit in cystectomy in terms of reducing transfusion and there was no safety signal there. But so in these 2 types of surgery, it doesn't appear to be a benefit. In cesarean section, a large study, 11,000 participants all across the country, TXA did not reduce transfusion and did not reduce bleeding. Doesn't work for cesarean section. I also noted here, it doesn't work in vaginal delivery either. It doesn't work in GI bleeding. Okay, so if you have an acute GI bleeder, TXA does not reduce blood loss or transfusion. It doesn't have any other effect either. There was no effect on thromboembolic complications or mortality, but there was no benefit. So another group in which you don't want to use it in. The group that it's been studied perhaps the most extensively, and it does work effectively, is in trauma. And these are a meta-analysis of a large number of randomized clinical trials, as well as observational studies. They include those who after trauma had surgery, didn't have surgery, and those who with and without traumatic brain injury. And overall, in these groups, it does work. It does reduce mortality by about 17%. Or the adjusted risk ratio by 17%. And then in this study, looking at giving TXA pre-hospital, what was its benefit? And what they found, if you give it early and you give it at a high enough dose, you get better benefit. So again, here you'll see this 3-gram dose was where you had the most efficacy, and if you gave it within an hour of trauma. All of these studies in which you give TXA, you want to give it, if you're giving it electively, you're giving it before the surgery starts, right? Before a skin incision. That's when you want to give it. I mentioned to you already that it does work in trauma in terms of improving survival. This was a study that went a little further and looked at, could you improve neurologic outcome if you give TXA in patients who have traumatic brain injury? And the answer is, unfortunately, you cannot. So in this study of 1,300 patients who had trauma, they did show similarly this reduction in mortality, as you've seen in other studies, similar types of odds ratio, but they did not improve survival with a favorable outcome. So whether or not then you think it's worthwhile, I think that if your people are surviving, you're giving them a chance to have a good life. In this case, at least in this study, it didn't improve their overall favorable survival. How about normal volemic hemodilution? That's when you take out some volume, some blood, and you replace it with crystalloid, let them bleed out lower hemoglobin at a lower blood at a lower hemoglobin, then replace the blood with the stuff that you took out earlier, right? And in that particular study, or in a series of studies which looked at in multiple types of surgery, there does seem to be some benefit, but it's small. Where it's been most well studied, again, is in cardiac surgery, where you do get benefit in terms of reducing the amount of transfusion, but it matters how much volume you take off. You have to take off enough volume, greater than 12 cc's per kilogram. And you also have to have enough hemoglobin to start with. So you need to have a hemoglobin greater than 12 to start with. So ANH may be useful, or probably is useful in select patients who have enough blood to give and have a high enough hemoglobin and they're having the right surgical case, but maybe not in everybody. How about cell salvage? This is pretty routine in most centers, and it's been pretty well studied. And it is effective. It's effective in cardiac surgery, it's effective in vascular surgery, it's effective in orthosurgery and joint replacement and spine. So very, very useful treatment to use here is cell salvage. How about DDAVP? This is a drug intravenously. What it does is it causes the release of von Willebrand factor from the endothelium. Is it effective in terms of reducing transfusion or bleeding? A lot of randomized trials, again, a lot of them in cardiac, here a good number in non-cardiac surgery. There might be some benefit. There doesn't really be much of a signal in terms of the proportion transfused or the need for reoperation. There was a slight decrease in the total volume of blood that was transfused, but it was small. The evidence level was low. Maybe something to consider, but I would say probably not something routine or you'd expect to be having much of a major effect. How about if you impose laboratory testing on your treatment algorithm? Don't just shotgun it, but use in point-of-care testing of labs to guide your therapy. And there's a number of randomized trials in this. Again, most of them are in cardiac surgery. And what the data suggests is if you are in a situation in which a patient is at high risk to bleed, and you put a transfusion algorithm that's based on lab testing, you will reduce the amount of transfusion that you give. So I think the data is pretty good there. And based upon that data, now the major societies are recommending that you have goal-directed transfusion algorithms using these point-of-care tests. Now, what does the algorithm look like? Which algorithm should you use? That's really up to you. There isn't any specific data. What you want to do is have some algorithm that allows you to test for platelet function and number. It should include some point-of-care test that evaluates the coagulation factors. For that, you'd give FFP or prothrombin complex concentrates, and you'd want to have some test that's measuring fibrinogen concentration, and for that, the therapy is cryoprecipitate. This is just a potential algorithm, but what test you'd use is up to you and your center. And this table just shows what are the three components there: coagulation factors, fibrinogen, and platelets. What are the thresholds of the types of tests you might use, and what the replacement therapy would be should you find an abnormality. How about fibrinogen concentrate? So you can use a product, a fibrinogen, as opposed to giving it in cryo or in FFP. And this therapy with fibrinogen concentrate has been shown to be effective, again, in the cardiac surgery side, and it's been shown to be cost effective. So if you compare fibrinogen to cryo in patients who have post-bypass bleeding, you will reduce the amount of cryo that you would give, makes sense, and it was cost effective at least in one analysis. And prophylactically, it's also been shown to reduce transfusion. And prothrombin complex concentrates, similarly in the cardiac surgical domain, have been shown to be beneficial in terms of reducing the volume of allogeneic blood that's transfused, as well as reducing the proportion of patients who are requiring transfusion in a couple of randomized clinical trials. Again, this is these studies, a lot of them are in cardiac surgery, so whether they apply to your practice, you'll have to decide. But certainly in trauma, which you might think analogous to some degree to the cardiac surgical population, cryo and prothrombin complex concentrates do not work when given prophylactically. So these are not therapies that you necessarily would want to give everybody, but in select patients, they might be effective. One of the areas I think is becoming a bit more controversial, certainly at our side, it seems controversial to me, I don't know if it's controversial to everybody, is should you be using, what type of blood should you be using in a trauma patient who has massive transfusion, or any patient who has massive transfusion? We certainly see patients in our institution, even without trauma, that need massive transfusion. And in the trauma literature, while this was studied, there is some suggestion that using whole blood is better than just using blood component therapy. This is a study that came out of Hopkins, colleagues whom I love dearly. And what you're seeing here is in this graphic is looking at what was the survival benefit comparing those who had been transfused with whole blood versus those that had this massive transfusion protocol without blood. And the y-axis here is the probability of survival. And what you can see here is in orange or yellow, however that's coming across, or red, those that got whole blood had better survival. In this study, this is a retrospective analysis from the NSQIP, TQIP database subsetting of NSQIP. And this was, in this study, the median amount of whole blood that was transfused was 1 unit. In patients who are massively transfused, which is essentially 10 units or more. And it just, for me, it's hard to understand how a single unit of whole blood could translate into a 10% absolute improvement in survival. If I had a therapy that did that, I'd be a millionaire. Maybe I'd be a billionaire. Maybe, who knows? But I can't imagine how this worked physiologically, but this is what their data had shown. This certainly requires more study. And when you are doing massive transfusion protocols, what should be the ratio of red cells to FFP to platelets? In our center, in many centers, it's 1 to 1 to 1. In the data here on the left-hand graphic, I'm showing you the data from the previous slide where they did use that massive transfusion protocol, 1 to 1 to 1. In the Japanese registry, what they did is they looked at their data and compared, what if we had a higher than 1 to 1 compared to a lesser than 1 to 1, where we have even more FFP compared to red cells. And in their data set, again, this is a retrospective analysis of their trauma registry, they found that those who got even more FFP at a higher ratio to red did better. And that's what that graphic is showing you on the right-hand side, where the odds ratios are all to the left of that line, showing that the high FFP was better. So when do the risks of and benefits of transfusion when do the benefits of transfusion outweigh the risks? Always, again, balancing risks and benefits. And there's been a lot of transfusion thresholds, a lot of evidence about restrictive transfusion. We definitely are clear now. We want to give as little blood as is necessary to get the patient at a safe hemoglobin level. I'm just showing you this table, a lot of randomized controlled trials in a number of different clinical settings. You can see transfusion triggers comparing generally 7 or 8 to 9 or 10. And in all of those studies, what they found is that you can transfuse less without worsening survival. Transfuse less without worsening survival. And this is just a meta-analysis of those showing that transfusing in the restrictive transfusion, 7 to 8 is better than that 9 to 10 in the studies that have been done with no safety signal in any of those outcomes. Now, based upon that, a few years ago, this is what the guidelines said. In critically ill patients, the hemoglobin trigger should be 7, less than 7. In cardiac surgery, it should be less than 7.5. In hip fracture surgery, it should be less than 8. And in GI bleeding, it should be 7 to 8. And what at the time, when this was published a few years ago, they said we need more data in patients with active coronary disease, having an MI, and those who have traumatic brain injury. We have some more data on those topics that I want to show you today. All right, so 2 trials in patients who've had active MI. So almost 668 patients, acute MI, hemoglobin 8 to 10. This excluded patients who've had an MI post PCI or CABG and in shock. They were randomized to a trigger of 8 or 10, and their outcome was, you see there, death, recurrent MI, stroke, or revascularization. And in this study, the hemoglobin trigger of 8 was non-inferior to 10. The hemoglobin of 8 was non-inferior to 10. And then this trial came out, bigger trial, 3,500 patients. And in this trial, over half of the patients had type 2 MIs. Everyone, again, had to have a hemoglobin less than 10, and then they showed a trigger of 7 to 8 versus 10. And their outcomes were MI and death at 30 days. And they found in this that the restrictive group did worse, or that those who had the more liberal strategy actually had a benefit. And this was at the border of statistical significance, at the border. Obviously, if you restricted, you were going to get less transfusion. And then there's another kind of sub-study of that looked at if you were to break down that data by the transfusion trigger, 7 to 8 was clearly not as good as 9 to 10. So here we have some evidence that maybe in patients who have an acute MI, including those having type 2 MIs, a lot of those we see perioperatively, that maybe a transfusion trigger of 9 is better than 7 or 8. Just one final slide here, again, on traumatic brain injury. Very interesting topic. So there's these 3 studies that have been published now in the last year. One in TBI, one in combined group of TBI, subarachnoid hemorrhage, and intracranial hemorrhage, another one just in subarachnoid hemorrhage. They had transfusion triggers of 10 versus 7, 9 versus 7, and 10 versus 8. Again, the transfusion triggers are a little bit different. In all of the studies, they essentially have the same types of results, favoring the liberal transfusion group. 2 of them are not significant, and 1 of them was. But if you look at that table, unfavorable neurological outcome, that's what we want, favorable neurological outcomes. We don't want the unfavorable ones. And the unfavorable outcomes were better. There was better outcome in the liberal transfusion. If you look at the numbers, again, all very similar, only 1 of them significant. What we're going to need now is a randomized trial, a bigger randomized trial, or a meta-analysis to figure out. So in conclusion, perioperative anemia and transfusion are associated with increased morbidity and mortality. Treatment of perioperative anemia with erythropoietin and iron does increase hemoglobin and decreases the risk of transfusion, but its cost effectiveness is unclear and it doesn't affect mortality. Certainly, prophylactic antifibrinolytic therapy with tranexamic acid works in a lot of surgical procedures, but not every single one, and it doesn't appear to have effect or minimal impact on thromboembolism. Hemostatic therapy guided by coagulation testing is going to help you reduce transfusion, and a hemoglobin of 7 to 8 is appropriate trigger for transfusion in most patients, but 9 may be appropriate in those who have acute MI and brain injury. Thank you very much for your attention.